From clinic halls to late night rounds, questions in your mind, cases, clues, and patient care, all in one straight line. This is the Clinical Medicine Podcast, where practice and the evidence meet. From bedside chat to breakthrough data, clear, concise, and right at your seat. The Clinical Medicine Podcast, making complex things feel clear. Tune in, learn on, stay curious. We're glad you're here. Oh yeah.
Hey everyone, welcome back to the show. Let's talk about something that can be pretty alarming. Blood in your urine. What exactly is hematuria?
Hematuria is simply the medical term for blood in the urine. It sounds scary, but it's important to understand there are two main types.
Two types? So it's not all the same?
Exactly. The first type is macroscopic hematuria. That's when you can actually see the blood.
Like my pee looks red?
It can be red, but often it's more brownish or even cola-colored, like a dark, murky brown. It's visible to your eye.
Whoa, that would definitely send me to the doctor.
Right? It's unmistakable. But then there's the other type, microscopic hematuria.
Okay, so this is where it gets tricky.
It is. With microscopic hematuria, your urine looks perfectly normal, like a healthy yellow.
So you wouldn't even know it's there?
Not without a lab test. It's only detectable under a microscope or with special chemical tests.
That's wild. So someone could have blood in their urine and not even realize it.
Absolutely. That's why routine urine tests can be so crucial.
It's like a silent signal then.
Precisely. The presence of these red blood cells, even if invisible, still indicates something is happening that warrants investigation.
So macroscopic, you see it. Microscopic, you don't. Got it.
So we've talked about what hematuria is, but how do doctors actually figure out what's going on once they suspect it?
That's where the urine analysis process comes in. It's a two-phase thing.
2 phases? What's the first one?
The chemical physical examination. It's basically looking at the urine's appearance, checking its pH, glucose levels, and importantly, hemoglobin.
So like how cloudy it is and if there's sugar in it?
Exactly. And if there's hemoglobin, it flags a possible issue. But that's just the start.
Okay, so after the physical and chemical check, what's phase 2?
The microscopic examination of the urine sediment. This is super crucial.
Why is it so crucial?
Because it lets us actually see what's in there. We're looking for erythrocytes, which are red blood cells, fibrin, and even blood clots.
So you can actually see the red blood cells under a microscope?
That's right. And seeing those intact red blood cells helps distinguish between different types of hematuria.
Like whether it's macroscopic or microscopic?
Yes, but also other conditions. It's all about what the sediment reveals.
That's pretty neat, going from a quick look to a microscopic dive. So it's not just about seeing blood, right? The color itself can tell you a lot.
Absolutely. The color of bloody urine is influenced by several factors.
Like what?
Well, how much blood is actually there? That's a big one.
Okay, makes sense. More blood, darker color.
Exactly. But also how long it stays in the bladder.
Retention time? Why does that matter?
The longer it's in there, the more it can change color. Also, the urine's pH.
The acidity or alkalinity.
Yes, that affects the hemoglobin. And exposure to air, which causes oxidation.
So air can make it darker, too.
Precisely. Now, when someone suspects hematuria, there's a clear protocol.
Walk me through it.
First, you request a full urine test, chemical and microscopic.
To see what's really going on.
Right. Then you interpret those results.
How do you do that?
If it's macroscopic, you note the brown color, any clots.
The cola-colored stuff.
Yes. For microscopic, you count the red blood cells under the microscope.
The invisible blood.
Exactly. Based on those findings, you plan further investigations.
Like imaging or a urologist visit.
That's the next step always. It's a structured approach.
So last time we talked about urine analysis, and now I'm hearing about hemoglobinuria versus hematuria. What's the difference?
It's key. Hematuria is when you have intact red blood cells, like actual full cells in your urine.
Okay, so actual red blood cells.
Yes, exactly. Hemoglobinuria, though, that's free hemoglobin. The red blood cells have already lysed or burst open, releasing their hemoglobin.
So it's like tiny bits instead of whole cells?
That's a good way to put it. Think of it like a broken water balloon. Hemoglobinuria is the water, hematuria is the whole balloon.
Got it. So how do doctors figure out if it's one or the other?
Great question. We use two main tools, a dipstick test and urine sediment analysis.
Dipstick, like what they do in the doctor's office?
Yep, a dipstick will test positive for hemoglobin if there's any blood present, whether it's whole red cells or just free hemoglobin.
So the dipstick can't tell the difference?
Precisely. That's why the urine sediment analysis is crucial.
Okay. So what does that show?
If the sediment shows no red blood cells, but the dipstick was positive, that confirms hemoglobinuria. The red cells are gone.
And if there are red blood cells?
Then it's hematuria. Simple as that. It's a two-step confirmation.
So the dipstick gets you in the ballpark and the sediment tells you the exact play.
That's a perfect analogy. The sediment is the definitive diagnostic tool here.
So we've talked about hemoglobinuria being free hemoglobin. What actually causes red blood cells to lyse, to break open?
Great question. There are a few main culprits. Think genetic conditions like microscopic or G6PD-H deficiency.
Genetic stuff, okay.
Yeah, these make red blood cells fragile. Then you have drugs or toxic substances that directly damage the cell membrane.
So certain medications could just pop them?
Exactly, or even some poisons. And then a big one is incompatible transfusion reactions.
Oh, like giving someone the wrong blood type?
Yes, their immune system attacks and lyses the transfused red blood cells.
That makes sense. What else?
Paroxysmal nocturnal hemoglobinuria, or PNH. It's a mouthful.
PNH. Sounds intense.
It is. It causes spontaneous lysis, often at night. And finally, rhabdomyolysis, or crush syndrome.
Rhabdomyolysis. That's when muscles break down, right?
Precisely. Massive muscle damage releases myoglobin, which is similar to hemoglobin and shows up in the urine.
So it's not technically red blood cells lysing, but it looks like it in the urine.
Visually, yes, the urine color is very similar, but the source is muscle, not red blood cells.
Wow, so many different ways for these cells to break down or for something similar to show up. So let's dive deeper into some specific conditions. You mentioned paroxysmal nocturnal hemoglobinuria.
Yes, this is super interesting because it's a defect in the complement system.
The body's own immune system, right?
Exactly. It causes red blood cells to spontaneously lyse, especially at night.
So people wake up with dark urine.
Spot on. It's often noticed first thing in the morning.
Wow, so the body attacks itself while you're sleeping.
Pretty much. And another critical one is incompatible transfusion reactions.
Oh, when someone gets the wrong blood type.
That's it. The recipient's antibodies attack the donor's red blood cells, causing massive hemolysis.
And not free hemoglobin then darkens the urine.
Precisely. It's a medical emergency.
What about rhabdomyolysis and crush syndrome? Those sound intense.
They are. Rhabdomyolysis is massive muscle damage.
Like from a huge injury?
Yes, or prolonged compression, which is crush syndrome. It was identified during World War II.
From bombings?
Survivors were developing acute kidney failure and dark beef tea-colored urine. That's myoglobin.
Myoglobin, not hemoglobin.
Right. Myoglobin is from muscle, hemoglobin from red blood cells. Both cause dark urine and can damage kidneys.
So it's crucial to differentiate what's causing the dark urine to treat it correctly.
Absolutely. It guides the entire treatment plan.
So we've talked about all these different causes of blood in the urine, but how do doctors really pinpoint if it's a kidney issue versus something else?
That's where erythrocyte casts come in.
Erythrocyte cast?
Yeah, think of them as little molds, cylindrical structures made of red blood cells found in the kidney tubules.
Molds of red blood cells? That sounds wild.
They're a huge diagnostic clue because their presence immediately tells us there's glomerular damage.
So a kidney problem specifically.
Exactly. They form when damaged glomeruli let too many red blood cells through into the tubules.
And then they clump up?
Right, like in glomerulonephritis, especially post-infection. Those red blood cells get cast into the shape of the tubule.
So if you see these casts, it's pretty much a guarantee of a kidney parenchymal issue.
Absolutely. It's a hallmark of true renal hematuria.
But what if it's just pigment casts, not actual red blood cells?
That's a key distinction. Pigment cast without intact red blood cells usually point to something extrarenal.
Like the rhabdomyolysis or hemolytic anemia we talked about?
Precisely. The morphology is crucial. Erythrocyte casts have distinct rounded ends, preventing confusion.
So seeing these casts under the microscope changes the entire diagnostic pathway.
It does. It shifts the focus directly to kidney health, specifically glomerular integrity.
That's super helpful for doctors.
It streamlines diagnosis and ensures the right treatment path.
So after all that, how do doctors even approach macroscopic hematuria?
It starts with a really detailed patient history. We call it anamnesis.
Okay, like what kind of questions?
They'll ask if there's a fever. That could mean an infection.
Makes sense. And medications?
Absolutely. Are they on anticoagulants, any nephrotoxic drugs?
Oh, so medicine could be causing it.
Exactly. And is it sporadic or does it keep happening? Recurrence helps differentiate acute from chronic issues.
Right, that's a big clue. What about after the questions?
Then comes the urine examination, specifically microscopy.
To see the red blood cells we talked about?
Yes, but we're looking for something specific, erythrocyte cast.
Ah, the casts, the ones that mean kidney damage.
Precisely. If we see those, it points to renal parenchymal hematuria.
So a kidney problem.
But if we only see pigment casts without red blood cells,
Then it's not the kidney.
exactly. That indicates an extrarenal process like hemolytic anemia or rhabdomyolysis.
So the casts really guide the diagnosis.
They're a critical piece of the puzzle for understanding where the blood is coming from.
So when we're talking about macroscopic hematuria, the blood you can actually see, how do doctors even begin to sort out what's causing it?
Right. It's really split into two big categories: medical causes and surgical causes.
Okay, medical versus surgical, what's the difference there?
Medical means it's usually coming from the kidney itself, the renal parenchyma. Think conditions like vasculitis or glomerulonephritis.
So inflammation or disease within the kidney tissue.
Exactly. Also, bleeding disorders like hemophilia or even taking anticoagulants can cause it.
That makes sense. What about the surgical causes then?
Surgical causes are more about structural issues or physical damage, like trauma to the kidney, say from an accident.
Oh, so external injury can cause it?
Yes, or even something internal like kidney stones. They account for about 11% of cases.
11%. That's quite a bit for stones.
It is. Another big one, especially in older men, is prostatic hypertrophy, which is about 13% of cases.
And what about more serious things?
Unfortunately, neoplasms, which are tumors. Kidney, bladder, prostate cancer. They're often silent, you know? Macroscopic hematuria can be the first and sometimes only warning sign.
Wow, so seeing blood even once could be super important then.
Absolutely. It's why we always investigate it thoroughly. Don't ignore it.
So that covers the main medical and surgical causes of macroscopic hematuria. But I hear there's this tricky one, renal angiomas.
Oh, absolutely. Renal angiomas are fascinating. They're basically these vascular malformations.
Like tangled blood vessels.
Exactly. Usually on the skin or nose, but sometimes inside a kidney calyx.
And these can cause hematuria?
Yes, especially in younger patients, but the diagnosis is super challenging.
Why is it so hard to find?
They don't show up on CT scans or angiograms. You need an ascending pyeloscopy.
Pyeloscopy?
Yeah.
That sounds intense.
It is. It requires a very skilled operator. It's an invasive procedure.
Wow. So that's for the macroscopic, visible stuff. What about microscopic hematuria, where you can't see it?
Microscopic hematuria means the urine looks normal, clear, but under the microscope,
You still find blood?
more than 5 red blood cells per high-power field. That's the diagnostic cutoff.
5? That's not a lot.
No, but it's enough to be significant. And here's the thing, the causes for microscopic hematuria are largely the same as macroscopic.
So trauma, stones, tumors, infections.
All of them. It's just a matter of how much blood is present.
So if it's that hard to diagnose angiomas and microscopic hematuria has all these causes, how did doctors even quantify how much blood is there?
That's a great question. Historically, there was something called the Addis count.
the Addis count?
Yeah, they'd correct all the urine over 24 hours.
Wow, that sounds tedious.
It was. Then they'd count the red blood cells and white blood cells in that whole sample.
So, like millions of cells?
Exactly. Over 1 million red blood cells, or sometimes even 5 million, indicated a problem.
But you said historically, so it's not used anymore?
Nope, it's obsolete. We have much better, faster ways now.
Okay, that makes sense. So modern methods are more accurate.
Yes, but accuracy depends hugely on proper sample collection. This is crucial for microscopic hematuria.
Oh, so like how you pee into the cup matters?
Absolutely. Contamination is a huge issue, especially for women.
Because of menstrual cycles, right?
Exactly. Or even just not cleaning properly beforehand.
So a false positive.
Precisely. If the sample is contaminated, you might see red blood cells that aren't actually coming from the urinary tract.
So it's really important to do a midstream collection.
Yes, and proper perineal hygiene. Otherwise, you could get a misdiagnosis of microscopic hematuria when there's no actual issue.
We talk generally about hematuria, but let's dive into something super specific. Dysmorphic red blood cells. What exactly are they?
Ah, the acanthocytes. They're red blood cells, but they've lost their normal biconcave disc shape.
Lost their shape? Like they're not round anymore?
Precisely. Instead, they have these weird cytoplasmic membrane protrusions. We call them blebs.
Blebs? That sounds not good.
It means something's happened. They form when red blood cells get damaged, passing through the glomerular basement membranes.
So like the filters in your kidneys?
Exactly. When those membranes are damaged, the red blood cells literally get squeezed through, and their internal stuff, the hemoglobin, leaks out.
Wait, so the blebs are from the squeezing and the leaking?
Yeah, it's a sign of a real struggle. And here's the crucial part for diagnosis.
Oh, tell me.
If more than 5% of the red blood cells in a urine sample are dysmorphic, it's a very strong indicator.
Of what?
That the bleeding is coming from the glomeruli themselves. It points to a glomerular origin.
So more than 5% dysmorphic means kidney problem, specifically the filter.
You've got it. It tells us a lot about where the hematuria is originating from.
That's super precise for something so tiny.
Absolutely. It helps narrow down the possibilities significantly, setting us on the right diagnostic path.
So we're looking for these squiggly, blebby red blood cells to tell us where the trouble is.
Yes, their messed up shape is a big clue.
So these dysmorphic red blood cells, these acanthocytes, what do they actually tell us diagnostically?
This is where it gets really interesting. Their presence, especially over 5%, is a huge red flag.
A huge red flag for what?
For glomerulonephritis. It strongly suggests that's what's going on.
So if I see these weird shaped red blood cells, it's probably a kidney issue.
Exactly. Because they're damaged from passing through the glomeruli.
Okay, but what if I see blood clots in the urine instead? Does that mean something else?
Absolutely. Clots are a game changer. They point away from the glomeruli.
Away from the kidney?
Yes, they suggest a urological source for the bleeding, like in the bladder or urethra.
So different signs point to different places.
Precisely. And we use a diagnostic table to put it all together.
A table? What kind of combinations are we looking for?
Well, dysmorphic red blood cells plus urinary casts, that's a classic sign for glomerulopathy.
Glomeruropathy, so the filtering part of the kidney again.
Yep, confirming glomerular damage. But if you see red blood cells and leukocyte casts...
Leukocyte casts? Are those white blood cell casts?
They are. That combination points to a renal infection, like pyelonephritis.
Wow, so specific.
And if it's just leukocytes but no casts with red blood cells, that's often a urinary tract infection.
Like a bladder infection.
Exactly, lower urinary tract. So the mix of cell types and these casts tells us so much.
It's like a puzzle, putting all the pieces together.
A very important puzzle. Each element is a clue.
So the morphology, the percentage, and the company it keeps with other cells?
Yes,
all critical for pinpointing the problem.
So beyond those dysmorphic red blood cells, what other pieces of the puzzle do we look for in your analysis when we're trying to figure out hematuria?
Okay, that's a fantastic question. We also have to consider urinary casts, leukocytes, and even blood clots.
Casts? Like little molds?
Exactly. They're like tiny aggregates of protein or cells that form inside the renal tubules of your kidney.
Oh, so like a mini cast of what's happening in there.
You got it. Their composition tells us a lot about where the damage is and what kind of damage it is.
That's wild. What about leukocytes, white blood cells?
If you see isolated leukocytes without those casts, it usually points to an issue in the lower urinary tract.
Like a UTI?
Precisely. Cystitis, urethritis, those kinds of infections.
And then blood clots. That sounds pretty serious.
It can be. If you find actual clots in the urine, that's a strong indicator the bleeding is urological, not glomerular.
So like from the bladder or urethra.
Exactly. Things like kidney stones, tumors, or even trauma can cause that.
So it's not just about seeing blood, but about the form it takes?
Absolutely. The type of cells, the percentage of dysmorphic red blood cells, and the presence or absence of casts are all crucial.
It's like a detective story in a test tube.
It really is. Combining all that information helps us differentiate between glomerulopathies, renal infections, and general urinary tract infections.
So every detail matters.
Every single one. It paints the full picture for accurate diagnosis.
Okay, so we've talked about what dysmorphic red blood cells are and what other markers mean. Now, let's zoom in on microhematuria.
Yes, microhematuria. This is when you have red blood cells in your urine, but you can't see them.
Invisible blood, so it's only detectable under a microscope?
Precisely. No visible symptoms, just microscopic red blood cells.
And how do doctors even start diagnosing something like that?
It begins with a really thorough medical history.
Like, how old are you, family history?
Exactly. Age, family history of kidney diseases, any urinary symptoms you might have.
Right, that makes sense. Then what?
Then a urine test, of course, to count those red blood cells and check for protein or other white blood cells.
Okay, so you get the numbers. What's the next step? Imaging?
Yes, first-line imaging is renal and bladder ultrasound for everyone.
For everyone, regardless of age?
Yes, it's the first choice for all patients. But then things change based on age.
Wow, interesting. So age plays a huge role in the diagnostic strategy?
A huge role. For younger patients, if microhematuria persists, a renal biopsy might be considered.
Only if other tests are inconclusive, right?
Absolutely. For patients between 35 and 60, after the ultrasound, a Euro-CT scan is usually next.
Euro-CT, is that to look for something specific?
Mainly to rule out tumors because the probability of neoplasia starts to go up in that age group.
So higher risk, more advanced imaging.
Exactly. And for those over 60, the probability of neoplasia is almost certain, so the protocol is more aggressive.
What's the protocol then?
Ultrasound, Euro-CT, and if that's normal, then a cystoscopy and other endoscopic exams are often recommended.
Cystoscopy sounds intense. That's if everything else is clear but suspicion is still high?
Yes, if the Euro-CT is negative, but clinical suspicion remains. It's a way to directly visualize the bladder.
And if no pathology is found after all that?
Then it's observation with periodic monitoring. Sometimes microhematuria can be benign.
So if those initial tests don't give us a clear answer, what's next for microhematuria? When do we go deeper?
Well, if microhematuria keeps showing up and those first steps like ultrasound are inconclusive, that's when we consider advanced tools.
Okay, so when would a renal biopsy come into play?
A renal biopsy is pretty serious, so it's only indicated if the microhematuria persists and everything else is still a mystery.
So it's like a last resort.
Exactly. We don't jump to it.
And Euro-CT scans, when are those most useful?
Euro-CT scans are primarily for patients over 35.
Why over 35 specifically?
It's mainly to rule out malignancies like tumors because the risk increases with age.
Makes sense. What if the Euro-CT comes back negative, but there's still a strong suspicion?
Then we might go for a cystoscopy or other endoscopic exams.
So that's looking inside the bladder, right?
Yes. Precisely. It's more invasive, so we save it for when we really need a closer look.
And what if after all these tests, nothing is found?
That happens. In those cases, the recommendation is observation.
Just watch and wait?
Yep. Periodic monitoring, because sometimes microhematuria is harmless and doesn't point to any significant pathology.
Wow, so it's not always a red flag for something serious.
Not always. Sometimes it's just capricious, as we discussed, or benign.
That's a relief to know there's a point where you just observe.
Definitely. It's about ruling out the dangerous stuff, and if it's clear, then we monitor.
So that was microhematuria, but what if you see blood in your urine with your own eyes? That's macrohematuria, right?
Exactly. When it's visible, it's macrohematuria, and this changes the diagnostic approach significantly.
So how do we start? Do we still think glomerulonephritis first?
Not usually as the primary suspect. If we rule out nephritis, then our suspicion for a problem in the urinary tract, like stones or tumors, goes way up.
Okay, so if it's not nephritis, where do we look next?
We follow a sequential procedure. It's like a clear roadmap to find the source of the bleeding.
A roadmap? Tell me the first step.
First, we go for imaging. Renal and bladder ultrasound is always the initial step.
Ultrasound makes sense. It's non-invasive.
Right. It gives us a good look at the kidneys and bladder for any obvious issues.
And if that's clear, what's the next destination on this roadmap?
Then we move to a UroCT. It provides much more detailed images of the entire urinary tract.
UroCT for better detail. Got it. And after that?
The final step in this sequence, if needed, is a cystoscopy.
A cystoscopy, that's where they insert a camera, right?
Precisely. It allows direct visualization inside the bladder and urethra.
So ultrasound, UroCT, then cystoscopy. Why this specific order?
This structured approach helps us quickly identify things like tumors, kidney stones, or any other lesions that might be causing the visible blood.
It sounds very efficient. So you start with the least invasive and move to more targeted procedures.
Exactly. It's all about pinpointing the problem as efficiently and safely as possible when someone sees blood in their urine.
That's a really clear pathway for something that sounds quite alarming to a patient.
It is alarming, but having this clear diagnostic sequence helps doctors get to the bottom of it fast.
Okay, so we've talked about all these diagnostic tools and markers. Now let's put it into practice with some real-world examples, right?
Absolutely. Case studies really bring it to life. Let's start with a young one.
A young patient? What kind of hematuria would a child typically experience?
Our first case is a 5-year-old with post-streptococcal glomerulonephritis.
Post-strep, so like after a sore throat?
Exactly. They had strep pharyngitis and then developed facial edema, less urination, and meat wash-colored urine.
Meat wash? That sounds concerning.
It is. It's a classic sign of inflammation in the kidneys following an infection.
Wow. Okay, next case?
Case 2, a 28-year-old woman with Buerger's glomerulonephritis, also known as IgA nephropathy.
IgA? What's that about?
She'd get cola-colored urine during viral infections and chronic microhematuria.
So it's not constant, it's triggered by something.
Often by infections, yes. It's when IgA antibodies deposit in the kidney filters.
That's wild, like the body's own immune system causing the problem.
Precisely. And for our third case, we have something called capricious.
Okay, so we've talked about all these diagnostic tools and markers. Now let's put it into practice with some real-world examples, right?
Absolutely. Case studies really bring it to life. Let's start with a young one.
A young patient? What kind of hematuria would a child typically experience?
Our first case is a 5-year-old with post-streptococcal glomerulonephritis.
Oh, strep? So like after a sore throat?
Exactly. They had strep pharyngitis and then developed facial edema, less urination, and meat wash-colored urine.
Meat wash? That sounds concerning.
It is. It's a classic sign of inflammation in the kidneys following an infection.
Wow, okay, next case?
Case 2, a 28-year-old woman with Buerger's glomerulonephritis, also known as IgA nephropathy.
IgA? What's that about?
She'd get cola-colored urine during viral infections and chronic microhematuria.
So it's not constant, it's triggered by something?
Often by infections, yes. It's when IgA antibodies deposit in the kidney filters.
That's wild, like the body's own immune system causing the problem.
Precisely. And for our third case, we have something called capricious hematuria.
Capricious. That sounds a bit whimsical for a medical condition.
It means the blood in urine appears intermittently, sometimes after physical exertion or even at rest.
So it's unpredictable.
Very. The key is there's no evident structural renal pathology.
No structural problems? So where does the blood even come from?
It's thought to be due to microtrauma or vascular hyperactivity in the glomeruli. The kidneys look fine, but the blood still appears.
That must be so frustrating for patients and doctors alike.
It can be, which is why understanding all these presentations is so crucial.
These cases really highlight the diversity of hematuria, from childhood infections to mysterious intermittent bleeding.
Yes, they show why a thorough diagnostic process is so important.
So we've walked through these incredible case studies. How do we pull it all together?
Right. We've got this great comparative table, a quick reference for distinguishing between different hematuria conditions.
Ooh, a cheat sheet for doctors.
Exactly. It lists the age, main triggers, the urine appearance, and the definitive diagnoses for each case.
So for the 5-year-old with the post-streptococcal glomerulonephritis, that's the meat wash urine.
Spot on. And the trigger was the strep throat.
The 28-year-old woman with Berger's, that was the cola-colored urine during viral infections, right?
Precisely. That chronic microhematuria, very telling.
And capricious hematuria is just that, capricious.
Intermittent. Sometimes after exercise, sometimes at rest. No clear structural pathology.
Okay, so these cases really highlight how varied hematuria can be. How do clinicians then navigate all this?
That's where the diagnostic flowchart from microscopic hematuria comes in.
A visual guide?
Yep. It starts with the initial clinical evaluation and urine analysis.
Then moves to imaging like what we discussed before.
Absolutely. Imaging and, if needed, biopsy.
And then it helps classify the hematuria?
Yes, into glomerular, tubular, or vascular causes. It's designed for rapid identification.
So it's like a roadmap for doctors to quickly pinpoint the problem.
Exactly. It takes all of the complexities we've talked about and streamlines the diagnostic process.
That's super helpful. So instead of just seeing blood, they know exactly what path to take.
It's all about guiding them to the right diagnosis efficiently.
So it sounds like we've really covered a lot today about hematuria, giving everyone a great framework.
Absolutely. It's all about that systematic evaluation, right? Not just seeing a lab result, but understanding what it means.
Exactly. And that's what this podcast is all about, building that understanding.
We really want to hear from you too. What nephrology topics are you curious about?
Your input is super important. It guides what we talk about next.
If you found this episode helpful, please consider hitting that subscribe button.
Yes, subscribe. Don't miss out on our upcoming lessons.
We've got so much more to explore in clinical medicine.
It's going to be really exciting. More insights, more clarity.
Thank you for tuning in with us today.
And we'll catch you in next episode right here on the Clinical Medicine Podcast.
Bye for now.
All right, I think that covers